Hello and welcome back, everybody. It's Jen Cook, and I'm one of the CVICU B attendings, and this is our second installment of hemodynamic monitoring in the CVICU. Dimitri.
Hi, I am Dimitri. I'm an internal medicine resident, as we know, and it's a pleasure to bring you this lecture that will be guided by Dr. Cook, which is, as again I say, a very great human being, the best there is, and yeah, hope you enjoy it. Yeah, so today we will go by a case, as we always go. We will start 1 second. So first case, this is a case. This is a 68-year-old female, prior history of heart failure with reduced ejection fraction. Last LV ejection fraction was 25 to 30. Coronary artery disease, hypertension, hyperlipidemia, who presents with new onset AFib with RVR and acute hypoxemic respiratory failure. On exam, the patient looks grossly volume overloaded. She has significant lower extremity edema and marked JVD with positive hepatojugular venous distension, I feel. This patient, we had her on the service. I was on cards wards, I remember. And we attempted to diurese the patient, and the patient's creatinine climbing and was climbing up. She was developing a higher AKI, and the person got hypotensive. So yeah. So this is a presentation of the case, which I feel we see it very frequently on the floors. This sort of patients. Some respond to diuretics, but some rather don't. But yeah.
Definitely a challenging patient.
So yeah, so my question, this brings us to the next slide, which is why, should we perform a right heart cath on this patient, right? Me sincerely, this, I feel we should, just to see her volume status and her hemodynamics, right? But this is again the why do we perform right heart cath slide that we have, and there's the why do we do them, right?
Yeah. So these are the 4 most common reasons why we might do a right heart catheterization. And in this patient, when you present her to me, I'm a little confused because she has this lower extremity edema and appears congested with the hypoxic respiratory failure. I suspect that she may have pulmonary edema, but when she got Lasix, she dropped her blood pressure. So really, there's a question of what's the patient's volume status at this point? And is this, with the arrhythmia and the rapid ventricular response, is she just, struggling for forward flow, or do we have the exam wrong? And so I think this is a situation where assessment of the volume status could be really helpful.
Yep. And yeah, and this patient, sincerely, this patient did got cold on night. I feel I was going towards her room and I touched her and she was getting a little bit colder. But not significantly, I would say. And yeah, she was just very concerning for me. And I like this patient is her physiology. I feel it's hard in my sense. But yeah, so this is again the few measurements we do get on a right heart cath. And here we're going to speak more about a few other things that we can see. We spoke in the previous slide about the TR we see and the pressure tracings we see with them, right? Anything that we want to add to this is very interesting, right?
If I could take an aside, I guess I can because I'm the professor. I get to do whatever I want to do, right?
Of course, always.
But this is the second video that we've recorded from this series. And the first one, we really talked about these tracings and how they're measured. But one thing we didn't talk about in the last session that I really would like to talk about here, just to, because it's such classic teaching, is this idea of the cardiac output and how we're measuring the cardiac output by thermodilution or FIC. And so one question that I would ask Dimitri is that one of the things that we would measure in this patient is the mixed venous oxygen saturation. And so do you have experience getting a mixed venous oxygen saturation from a patient, either in the cath lab or the ICU?
Yeah, I do, sincerely, but we do have to get the mixed venous. I know a few times we just do it with how do you call this, the cordis. But I know the truth is that we have to get it from the PA per se, right?
That's right. That's right. So what you want to do is you want to measure the oxygen right before it's oxygenated. And so if we take a look at the top figure, we see that in the PA, which is the third figure, from the left in the top right, you can maybe show with your arrow where this one is in the PA. When we take the mixed venous sat from the PA, we're getting the blood right before it is oxygenated. Now, typically we don't have much of a step up as the blood goes from the right atrium to the right ventricle to the PA. And in fact, there's not much of a step up from the superior vena cava or the inferior vena cava. So sometimes when we don't have access to the PA, we'll get a mixed venous sat from these other locations, like from a central line or something like that. But the concept is when we're talking about the PA sat, a couple of different environments that we might get it is we might get it in the cath lab or the CVICU in a patient in cardiogenic shock. But I know that there's sometimes when we get a mixed venous sat in the MICU.
Yeah.
And so why do we get a mixed venous sat in the MICU?
So why do we get it? This is like I feel I'm a person that I would love to swan in the MICU per se, but sincerely we do receive it in there to see if it's high or to see if it's low, and we can say if the person is having a distributive shock status versus a low cardiac output state, right?
That's right. That's right. And so if you think about it, the hemoglobin carries the oxygen throughout the body, and our ability to extract oxygen from the hemoglobin is very efficient. And so the longer the blood is in contact with the periphery, the more oxygen that is taken out of the blood. And so the faster the blood is circulating, the less oxygen that's taken out of the blood. And so the mixed venous sat is the saturation when the blood returns to the heart to get oxygenated again. And so if the blood is traveling very fast, there's going to be a higher concentration of oxygen when it returns to the heart. But if the blood is moving very slowly, there'll be a lower percentage of oxygen. Now, the percentage of oxygen when the blood returns to the heart can be compared to the percentage of oxygen in the oxygenated, so in the arterial system, and that with an equation can lead to a cardiac output. And that equation, of course, is our FIC equation. And so one way that we're measuring cardiac output with a SWAN is by FIC, which is a mixed venous sat. The second way we measure cardiac output in a SWAN is with thermo. And what thermo is basically a thermometer that's placed at the tip of the PA catheter with colder, so liquid that's room temperature, which ends up being colder than the blood, being injected in the right atrium. And so what the SWAN catheter is able to do is to measure the temperature change when this cold, so to speak, fluid travels from the right atrium to the PA. And so assuming that all the blood is moving forward, well, we know that with tricuspid regurgitation, there's mixing, but assuming all the blood moves forward, the amount of time it takes for the blood to warm up again after this cold fluid is injected correlates with the cardiac output, and that's the thermodilution. And so oftentimes when your patient comes back from the cath lab, you're going to have a thick cardiac output and a thermocardiac output. And then at University of Cincinnati, and let me tell you, this varies from unit to unit. So if you go to train somewhere else or you go to practice somewhere else, you'll see that the units do a different, may be measuring their cardiac outputs differently in the ICU. But in our ICU, we're getting PA sats. And then the nurses are calculating with the Fick equation, the cardiac output. And so I just wanted to introduce that to everybody because we did a nice job of talking about the tracings in the last presentation. And I think it would be helpful to do a very short primer on the Fick versus thermo.
Yeah. Yep. Sincerely, it's harder to understand the thermo, but it does make sense, sincerely. Yeah. No. Just for me to ask, do you have a preference between any of them?
Well, there are pros and cons to both. So the thermo we're actually directly measuring. And as long as you have the correct temperature of the fluid, you have the exactly 10 cc's of fluid, and the blood is moving in one direction, meaning that there isn't a lot of TR, the thermo can be more accurate, with the exception of extremes. So a lot of my patients have a really low cardiac output, and the thermo can be less accurate if the cardiac output is quite low. And so those are the drawbacks of the thermo. Now, the drawback of the Fick, I like it because you get a PA sat and you compare the PA sat at 4 a.m. to 4 p.m. and they're two distinct numbers. And if it's going down, you think maybe the cardiac output is going down. The drawback of the Fick is that the Fick equation, the numerator of the Fick equation is the oxygen consumption. And the oxygen consumption is the amount of oxygen that we're burning. And so when we calculate the Fick equation at the bedside, we're using the oxygen consumption based on the patient's height and weight, so the patient's BSA. But we know that's not the true oxygen consumption because our oxygen consumption changes as we're exercising. And so one challenge of comparing a PA sat at 4 a.m. to a PA sat at 4 p.m. is that the oxygen consumption when the patient is asleep at 4 a.m. might be quite lower than the oxygen consumption at 4 p.m. when the patient just finished a walk with physical therapy. And so you need to be careful when you're comparing the PA sats and the Fick equation calculated cardiac outputs because of the variable oxygen consumption.
Great. Yeah, that's pristine. But yeah, a few things also that I have to say for the people who will be on the CVI is when you have this tracing for the specific patient we are seeing now with new onset AFib, you will not see an A wave, right? Mm-hmm. on the tracing, which I think is very nice.
Correct. Yeah. And the size of the waves will be proportional to the diastolic filling time. So if you see a larger R to R interval, after the large R to R interval, that next beat will be larger. And so that's something that when someone is in atrial fibrillation, you need to average out several in order to get the true filling pressures. It's a good point. So do we have numbers for this patient?
That's nice. We do have numbers for this patient. So RA of, so yeah, I will spill them to you right now. So this person was taken to a cath lab for sure. Got dipped, that's what they like to say. Showed an RA of 30 with a V wave of 37. Showed a RV of 60/13. PA showed a PA of 60/20 with a mean of 33. Pulmonary capillary wedge pressure of 20. Ooh. Cardiac output by Fix 5.4, cardiac index 2.4, and the AO pressure, the aortic pressure was 122/87 with a map of 95.
Okay. Oh, this is beautiful. So this was so this is demonstrating that large V wave.
Yeah.
That's beautiful. So
for the patient. Yeah, exactly.
And so the patient has a large V wave, which means they likely have some tricuspid regurgitation. And so we might be leaning more on the FIC than the thermo here.
Thermo, yeah. Yep. And yes, but a few things that we see here, right? Do we want to say a few things?
Yeah. So what do you think of these numbers?
Yeah, this person, first thing I would say, right? The wedge is high for sure, and her CVP is high inclusively, I would say. CVP is very high, and she has high right-sided filling pressures. Left side, we can say they're high by definition. But this is a hard case because we tried to diurese the patient, right? And didn't work, I feel, right? She was not having no output. I would tell you, I'll be sincere.
Yeah.
But yeah.
So I guess then we kind of walk into a conversation about pulmonary hypertension, don't we?
Oh, yes.
Is that where we're headed?
I feel like it, yeah.
Okay.
Yeah.
So tell me about the pulmonary hypertension.
1 second. Yep. I will tell you about it. So that's the first thing we say, right? That she has pulmonary hypertension just by if you define pulmonary hypertension, new definition of pulmonary hypertension is pulmonary artery mean pressure of 20 or more milliliters of mercury. But what defines also that's that with previously it was 25, but now it's 20. That's the main definition of it. But what we ask ourselves is, what is the driving cause of the pulmonary hypertension, right?
Sure.
And there's where we go towards like seeing what is the first of all, we see the wedge. I feel you see if it's more than 15, you can say it's due to a thing, and then you have to calculate a few other calculations. But by definition, this person has pulmonary hypertension. We need to figure out why, right?
Sure. Yeah. So it's easy for me because all of my pulmonary hypertension patients have the same etiology, but maybe we should start with a review of in the world of pulmonary, in the world of internal medicine, what groups the patient fits into. So so we have them listed here. Which group does this patient fit into?
So if it's in our service, I feel has to have the WHO group type 2, right? Yeah, that's what I feel. But to define a WHO type 2, person has to have some sort of dysfunction of the cardiac muscle in the left side, and have to have a high mean PA, and please correct me if I'm wrong, high mean PA and a high wedge pressure also, right?
Yeah. Now this patient that you're presenting to me right now has heart failure with reduced ejection fraction. So it's very easy to understand, that they have elevated filling pressures and pulmonary hypertension related to left heart disease. Many patients that we see that have pulmonary hypertension will have heart failure with preserved ejection fraction, where the wedge pressure might be 18. And in that case, it can be a little bit more nuanced. For instance, that it is the left-sided disease. But in this patient, clearly with this heart failure with reduced ejection fraction, I think this is a group 2 pulmonary hypertension patient.
Yep. And yeah. So we should say this person has pulmonary hypertension. And then I feel what to do with this patient. We'll go with it with Dr. Cook, the expert on this.
Yeah. So what's our next slide then?
So yeah, so our next slide is you're doing.
Oh, wonderful. Yeah. So the thing that's important for us to understand is really understanding how these patients that have left-sided heart failure develop pulmonary hypertension over time. And so physiologically, this is something that I want us to have kind of a living, breathing understanding of. So I created this figure. And so what I've done here is I've separated the left and right sides of the heart and put the lungs in between. And so the pathophysiologic process is that with left ventricular dysfunction, whether this is from heart failure with preserved ejection fraction or reduced ejection fraction, you get an increased left ventricular and diastolic pressure, which is then transmitted to the left atrium, which is measured then by an elevated pulmonary capillary wedge pressure. And that pressure is seen in the lungs. And so if you advance it for me. And so let's say this patient has a wedge pressure of 20. The wedge pressure of 20 then leads to pulmonary venous hypertension. And so you can imagine for patients that are in the class 2, so WHO class 2, the heart failure doctors and the cardiologists have further separated these patients into 2 groups. The patients that have pulmonary arterial hypertension or pulmonary venous hypertension, also said pre-capillary and post-capillary pulmonary hypertension. And so the pre-capillaries are on the left-hand side of the lungs and the post-capillaries are on the right side. And so what we see is that when there is, post-capillary pulmonary hypertension, that's pulmonary venous hypertension, it can lead to swelling in the capillaries and pulmonary edema. And as this is present over time, the pulmonary vasculature actually can hypertrophy. And so when seeing these high pressures, there's hypertrophy of the pulmonary vasculature that leads to pulmonary arterial hypertension. And that is the transpulmonary gradient. And the transpulmonary gradient then is then described as pulmonary vascular resistance. And so if you advance the slide one more time, you see that this patient, so the mean PA pressure is the pressure in the green. That's the pressure before the lungs. That's what we're measuring when the Swan-Ganz catheters in the PA. And then we're comparing that to the pulmonary wedge pressure, pulmonary capillary wedge pressure. That's the transpulmonary gradient, and that's the pressure gradient across the lungs. And so in our patient, but then we take that actually, I think if you advance it one more time.
Yep.
So if you've seen the transpulmonary gradient before, it might look familiar to you because it is the numerator of the PVR equation. So this transpulmonary gradient is the numerator taken over the cardiac output, gives us our pulmonary vascular resistance. And so in our patient who has a pulmonary capillary wedge pressure of 20, then we have a transpulmonary gradient of 13 because there's a mean arterial right atrial pressure of 30. And so this transpulmonary gradient in our patient, this is a different demonstration, but you can calculate our transpulmonary gradient in our patient that you're presenting to me. And so let's do that next. I think if you advance the slide, we go, oh, I know what I was trying to say. Okay, so basically after the transpulmonary gradient is elevated, over time, what can happen is that you can get further backing up of this fluid. And so typically, a normal right atrial pressure is like around, 6 to 8 or something like that. Yeah. Our patient has a right atrial pressure of 30. And so what is happening is that there's increased right atrial pressure. And when you see a situation like this with a right atrial pressure of 30 and a wedge pressure of 20, you know that is very unusual. Because typically the wedge pressure is higher than the right atrial pressure. And so when you see that, you know that this is someone who's got a very sick right ventricle and has chronic disease, the left heart failure. And this is really right heart failure due to left heart failure with the interim step of pulmonary hypertension, really due to pulmonary vasculature remodeling from chronic left-sided elevated filling pressures.
Yep, and the patient's PA, it was 33, which if you subtract it by 20, it equals 13. Yeah,
very good.
So this is very good. Good slide there. And then we lead to what is with her numbers. What do we do, right, doctor? This is what we want.
That's right. So do we have 2 options here? Oh, yes, we do. Yeah. Okay. All right. So what we have here, this is an exercise because I just taught you something, but I find that if we use that information and an exercise, that it helps to bring it home a little bit. So what we've done here is, if you take a look at the left-hand side of the slide, we have two patients now. We have a patient that has a right atrial pressure of 30, with a PA pressure of 60/20, with a mean of 33 and a wedge of 20, a cardiac output of 5.4. And then we have the bottom patient who has a right atrial pressure of 18, PA 80/25 with a mean of 43, wedge of 25, and a cardiac output of 4.2. So the question is, which patient has the healthiest right ventricle?
Yeah.
So Dimitri, did we ever do this on rounds together?
I feel so. Yes.
Yeah. Because whenever I do this on rounds with people, I usually draw this up on the whiteboard, and this only works if somebody in the group says one and the other person in the group says the other. But this is really when the growth mindset comes up, because you have to be willing to be the one that's learning. So with a big group, with our, students and our residents, this is a lot of fun. But one thing that you, but let me just so that you could kind of be there. So let's say you're there on the wards with me, somebody inevitably would say the top. And so the question that I would have, if you choose the top as being the healthiest RV, and if you animate it, what we need to do is we need to figure out what is the transpointed gradient. So if you click on it, so what is the transpointed gradient? So the transpointed gradient, I still have my trusty calculator here in front of me.
Yep, we did it.
We did it. Okay, so the transpointed gradient is what? 33 divided by 20, which is 13. All right.
And then we calculate PVR.
And the PVR is that over the cardiac output.
Yep. It's
2.4. All right. And then do we compare that to the second group of numbers?
Yeah, for sure. I'll put it in.
Okay. All right. So the learning point here is that although many people would choose the top RV as being the healthier RV, because the cardiac output is higher and the PA pressures aren't quite as high, it's important to recognize that the actual healthiest RV is the bottom one. And the reason why the bottom patient is a healthier RV is that a right ventricle that's able to mount pulmonary hypertension has better contractility. So a couple ways to look at that. One is the pulse pressure in the right ventricle. So the pulse pressure, so that comparing the systolic to the diastolic pressure of 80/25, that is, I can't think well on my feet, is a pulse pressure of 55 versus the pulse pressure of a PA of 60/40 is only 40. So the stroke volume of the bottom right ventricle is greater. Finally, and this was an aha moment I had very late in my career, but we talk about the left ventricular end diastolic pressure, and we think about the left ventricular end diastolic pressure as being the wedge pressure, and that tells us a lot about the physiology, and we really understand the preload and afterload effects of the left ventricular end diastolic pressure. Well, when you start to think about the RV, one thing that you can recognize is the right atrial pressure is basically the left ventricular end diastolic pressure. And so once you think of it that way, you recognize that a patient that has a right atrial pressure of 30 has very high preload on the RV, and it really is not moving that blood forward. And so that is another reason why. So just to summarize, the healthiest RV is the RV that's on the bottom of this, and it is because there's a greater stroke volume in the right ventricle, a higher pulmonary arterial pressure, and a lower right ventricular end diastolic pressure, so a lower right atrial pressure. There are some ways and some calculations that we can use in monitoring or in defining the right ventricle, and one really popular one is the PAPI, which is the pulmonary arterial pressure minus the diastolic pressure over the right atrial pressure. And we'll see that in the case of these, the PAPI is definitely lower in the sicker ventricle.
Yep, it is. But yeah, and then for this patient, what do we do? I feel, right? That's my question. But yeah.
Is that our next slide as well?
That is our next slide. Yeah, for sure.
Okay. What do we do? What do we do with this patient? So now we're back to our original hemodynamics, right? With the wedge of 30.
Yeah, I'll put it in.
Oh, good. You got it. Okay. So PA wedge of 20, right atrial pressure of 30. All right. So let's talk about each of these then. So you already got Dr. Cook. So D, we're on board. So pulmonary vasodilators, what are our options for pulmonary vasodilators? What have you seen used, Dimitri?
I've seen use inhaled Velitri or
Okay.
inhaled, yeah.
Inhaled Velitri and inhaled
Uh,
nitric oxide are the two that
uh,
you'll see used. Yep. And so what do those drugs do? Like what physiologic changes do they bring about?
they dilate the pulmonary capillaries, right?
Yeah, so they're pulmonary arterial vasodilators.
Dilators.
And so this patient currently has a transpulmonary gradient of 13, so it would decrease the transpulmonary gradient. And so a pulmonary vasodilator is going to decrease the transpulmonary gradient and allow easier blood flow from the right side of the heart to the left side of the heart. So how would that likely affect this patient?
So yeah, so I was seeing this in my head right now, right? And it's like the same as we decreasing the afterload, like in the LV, but in the right side, and this will flood more the LV, like I feel, right?
Absolutely, absolutely. And so if you give this patient a pulmonary vasodilator, you're going to decrease the PVR and you're going to increase the amount of blood flow that's going from the right to the left. And this is in a patient who has an elevated wedge pressure and pulmonary edema already. And so you run the risk of actually precipitating further pulmonary edema and higher left-sided filling pressures. And so a pure pulmonary vasodilator is risky in this situation.
Yeah. His patient, like I was seeing this patient, I feel this is a hard physiology because this person is also, as you see it, a bit hypertensive, per se, and this person has a reduced DF. So like placing this person on inhaled pulmonary dilators, I feel it's not it's not bad, but we have a lot of risk because we can flood that LV, which is very bad per se.
Yeah. And so one of the things that you said that someone who's watching might disagree with you is that the patient's hypertensive. This just means that you've really been drinking the Kool-Aid rounding with me. So can you tell me why you think this patient's hypertensive? Because there might be some people who disagree with you.
Yeah. So I take that mean arterial pressure is 95, which it is very high for that sense, I feel, right? Plus,
Yeah, so most of my patients have maps that are like in the 60s, 65 is lots of blood pressure for me. So a map of 95 is definitely hypertensive in the heart failure world, which really opens up the door to systemic vasodilators for us.
Yeah. And that's what this patient got sincerely. And just with that, she started, as we described in the previous case, like just with that, the patient opened up, honestly.
Yeah, because if we go back to, and I don't think we have these equations here, but the patient definitely has this elevated right-sided filling pressures and pulmonary hypertension. But if we go back and calculate what the SVR is for this patient, so that's going to be the MAP, which is 95 minus the right atrial pressure of 30, divided by the cardiac output of 5.4 times. Yeah. So wait a second.
Yeah. No. This is what we, like I called you for this.
Did we do this? Did we do this? So are you guys watching? I want you guys to pull out your phones. All right. So pull out your phones and do the calculation with me. Let's do it one more time together. 95 minus the right atrial pressure of 30 is 65. Divided by 5.4 times 80. I'm getting I'm getting 962.
Yeah. Yeah.
So this is
Exactly.
so fascinating, right? So this is like one of my favorite things to teach. And so what just happened here? What just happened here is that we were talking about this patient that had a high SVR state. And then I just calculated using my handy calculator, the SVR, and got 962, which is much lower than I would have expected it to be. And honestly, the reason why this case has become a memorialized case is that when Dimitri first saw this patient and the patient came back from the cath lab on systemic vasodilators, was really puzzled because the SVR was low. Now,
Yeah.
this is the whole purpose that I took you through the exercise of the transpulmonary gradient and the right ventricular function, because this SVR in a patient, the systemic vascular resistance, can be measured by putting a resistor in the periphery, right? Because this is physics. This is what we learned in physics, that you measure the resistance, with a resistor. We can calculate the systemic vascular resistance by the calculation that I taught you as far as the mean arterial pressure minus the right atrial pressure, but we're assuming that the right atrial pressure is reflecting the left ventricular function. And so in patients that have right ventricular failure, the right atrial pressure becomes uncoupled from the physiology of the heart. And so the right atrial pressure that's elevated is not the same as a right atrial pressure of a septic patient in the MICU who no longer has a high SVR state. This is somebody who has a right arterial pressure that's uncoupled from the left-sided pressures because of the complicated hemodynamics of the elevated transpulmonary gradient and decreased contractility of the right ventricle. And so don't be fooled. And actually, sometimes, I've rounded in different environments, and I've had some attendings that have been my partners that have really followed the SVR on rounds and are calculating it on the patients on every time. And actually, I don't really do that so much because I'm really thinking about the SVR. The biggest determinant of what the SVR is what the map is. And then you factor in the right atrial pressure and thinking about, does it reflect what the filling pressures of the body is or not? And this is a perfect example of the right atrial pressure is 30, but the wedge is 20. So we know that this is uncoupled. But if you think about the equation for the SVR, the largest number in the equation for the SVR is the mean arterial pressure. So we basically treat the mean arterial pressure, and it trumps any calculation that we can make.
Yeah. Sincerely, that's why I took D in this patient, because I didn't know what to do, honestly. Sincerely, like it blew my mind. Like and when I was told that this person is hypertensive, I was like, what? Because I saw the SVR, and I said, like, well, like I cannot reduce more like the afterload, but this patient did got systemic dilators, and this person got more hypertensive, and then he diuresed them, because she wasn't perfusing and she wasn't having that output. And when they put her when they gave her the systemic vasodilator, she started having that urine output. Sincerely.
Yeah, having kidneys that work is a beautiful thing when you're managing heart failure, isn't it? Because if you give them blood, they'll create urine.
Yeah, sincerely, like it was very, that's like the art, sincerely. Like that's why this case was very, very complicated for me, but it's very pretty if you understand the hemodynamics as the D option would get you. Yeah. So yeah, that's the end of this case. Well,
Okay.
This is the summary of the case that we just saw, where we saw the basic concepts of heart failure with reduced EF and high pulmonary filling pressure. We went over also the pulmonary hypertension groups and the diagnostics of it, as you can see here. We also have the new definition of pulmonary hypertension, And we saw that in the CVI, we just see type 2. But yeah, sincerely, it's very nice. A thing that I remember that I do a lot on how we remember the pulmonary hypertension groups. I have, I know there's 5 who groups. The first one, I say there's one pulmonary artery, basically. And there's like, that's the first group. It's like pulmonary arterial hypertension. Then the type 2, I see there's 2 chambers. There are 2 heart chambers. There's the left ventricle, there's the left side heart, and there's the right side heart. Also, there's 2 atriums and 2 ventricles. So it's the type 2 for the heart. For the WHO group 3, I see like a blow, like a puff, and I consider it like a 3. If you put in this emoji I have there, it can resemble like a 3. That's why I put it in there. And then WHO type 4 is the chronic thromboembolic hypertension group, or the CTEPH as they call. And I picture just 4 words like chronic, and I put together a thromboembolic pulmonary hypertension, which is 4 letters, or CTPA if you want, which is also what you do. And then the WHO type 5, in the Roman numerals, V is a 5. So I just take the V as variable, or that's that's a multifactorial one. But yeah, this is basically
Mnemonic.
how I see it in my head. But yeah, that's it for this primer. I appreciate a lot, Dr. Cook, for the time invested in this and for the guidance and all.
Well, thank you for bringing these cases. I think it's a lot of fun to talk about this physiology, and we wanted to give everybody just a little bit of a primer, so that when we are looking at these SWAN numbers, that you have a frame of reference and a place to get started. So thanks for tuning in, and we look forward to seeing you all in the unit.